Obamacare may have moved America's healthcare system closer to what we have in Canada, but both systems still feature financial burdens placed on the patient, as well as other common problems and inefficiencies that are transforming both our healthcare systems. So, joining us now to tell us more about these changes, Trudy Lieberman. She is contributing editor for the Columbia Journalism Review and past president of the Association of Healthcare Journalists in the United States. And André Picard is here. He's public health reporter and columnist with the Globe and Mail. And André, it's good to see you again. Trudy, nice to have you on the program for the first time.
Thank you.
I know everybody's been following all of the drama south of the border, and it's all a big fight which has its genesis in Obamacare. But I still think there's a lot of people who don't really know what Obamacare is. So will you help us out, Trudy, and just give us your handy-dandy definition for what it is?
It's basically a way to expand health insurance to more Americans who have not had insurance to cover health problems. So we had about 51 million people who were uninsured at the time the Affordable Care Act passed. And after the act is fully implemented, we're still going to have around 30 million people who will still be uninsured. So at its core, it extends coverage to a certain number of people in the U.S. population.
So even after all is said and done, there will still be millions of Americans not covered by health insurance, even with Obamacare.
That's correct.
How come?
Well, because we don't have a truly universal system. We do not have social insurance. It's not a social insurance program. We have basically just tinkered with the private model that we have and improved one of our insurance markets to make it more easy for people to join it and to buy into it. In other words, that market has become more palatable to certain people who had been excluded from buying in that market because they had pre-existing conditions or they couldn't afford it.
They had a big debate about whether or not to include single payer as an option, and they rejected it, right?
Well, I wouldn't say the debate was really big.
Short.
It's short.
Short but intense.
It's been off and on a part of American thinking for many, many decades. But we don't seem to want to do that. And Americans believe that it's socialized medicine. We have an aversion to that. Americans are not willing to embrace that. They're worried about waiting lists. So I think people who once supported single payer sort of decided this Obamacare is about the best they can do.
Well, let's take a look at some of the affordable care options. And control room, if we can bring this up, please. There are a number of different plans that you can buy under the Affordable Care Act. And here is the percent of the expenses that are covered by all of the different plans. And I guess almost like Olympic medals, you can get a bronze coverage, silver coverage, gold coverage. They have an extra one, platinum coverage. But even with platinum, it still only covers 90% of the expenditures. You're still going to go into your pocket for some of the things. What happens if you still can't afford even a bronze plan?
Well, you have the choice of not buying a policy and staying outside the system. We have an individual mandate that's part of this, which means that every American, with certain exceptions, has to be covered by insurance. So if you're not covered by your employer or our Medicare or Medicaid program, which are public programs, you can shop in these shopping exchanges in what we call the individual market. These 4 plans you mentioned are the ones being sold in the individual market. So if you can't afford even the cheapie plan, you can go without and pay a penalty, which is really quite small at this point.
One more thing before we get André involved, and that is most of the, if I can call it this, civilized world has some kind of universal health care component. The United States does not. And, you know, obviously a wing of the Republican Party tried to bring down, in a sense, close the government and mess around with the debt ceiling in order to show its opposition to Obamacare and try and get it killed. My hunch is there's a huge chunk of the population outside the United States that finds this all bewildering. What's your take?
It is rather bewildering. I've covered national health systems for about 2 decades now, and I know how many other systems, including Canada, works. And it is very bewildering why we don't embrace other countries and the best of what other countries have to offer. I mean, no country has it perfect, and there are challenges in every country and every kind of system. But during the debate on Obamacare, we kept hearing that Americans had the best health care in the world, and that we were the exception, and that we would really go our way and create a uniquely American system. And that is pretty much what we've got.
Enjoy.
Thank you.
All right, André, here's what you had to write in the Globe and Mail not too long ago, actually, last week. The grandiloquent purpose is to ensure that all Americans have health insurance. After all, among the 50 wealthiest countries on earth, the U.S. is the only one without universal health care. Obamacare won't get it there, but it will make insurance a little more available and affordable for some. Canadian Medicare, for its part, is becoming less universal and affordable, but we don't like to talk about that. Well, we're going to talk about it now. Why do you think it's becoming that way?
Well, essentially in Canada we have, if we want to use the American analogy, we have a silver plan. So about 70% of our care is covered publicly, and 30% we have to pay either with private insurance or out of pocket. Canadians are the largest out-of-pocket spenders of insurance in the world outside the US. So we spend a lot of money outside of our Medicare system. So there's universal health care, but it has a little asterisk at it.
Well, it's a big asterisk, actually.
It's getting bigger.
$62 billion worth of private spending in our single-payer, universally covered, socialized medicine system, if I can put it that way.
Exactly.
That's a big asterisk.
It is, and essentially what we have, to use the technical term, a bifurcated system. We're also unique. We're the only country in the world that has this. We cover 100% of hospital and physician care, and we cover various amounts of other things, about zero for dental care, right through to about 50% for drugs. So all across the board, there's these other things that are really important to your health and your medical care, but they're not part of the universal plan.
Just focus on this a little more. We have a lot of new Canadians watching this program who may not know. What do people have to go into their pocket to pay for as part of healthcare in Canada today?
Well, the main one is drugs. So we use a lot of drugs. It's a big part of care now. Most people get drugs through their employer or through a public plan. They're a public plan for seniors and for people on welfare, for example. We have to pay, say you have to get to the hospital, you have to pay for the ambulance. You might pay extra for if you don't want a ward room. So for a semi-private room, you'll pay for your crutches, you'll pay for your dental care, you'll pay for your physiotherapy. All kinds of things get delisted. So we are quietly working away at, well, we can't quite afford this in the public system, so we quietly move it over to the private. Now, is this good or bad? That's debatable. What's wrong about what we're doing is we're not really discussing it. We're kind of doing it in the back room. The one good thing about the US is they're having a fight about it. There's actually a debate. It's not always about health care, but we're not having any discussion at all about our changes.
Why do you think?
Well, I think Canadians have a lot of mythology around their health care. We love our Medicare system. There's really good things about it. The care is wonderful, but we kind of romanticize how good it is. And we forget to compare ourselves to others other than the US. If you look at the US system, we can feel pretty good about ourselves. If we look at France, Norway, Denmark, you feel a lot less good. They have their platinum and gold plans. We're still down in the silver.
But if I recall, and I think I read this in Jeffrey Simpson's book, your colleague at the Globe and Mail, Tommy Douglas, the former Saskatchewan Premier, never intended Medicare to cover absolutely everything. It was never meant to be. Regardless of what you need in healthcare, it will be covered by the taxpayer. So this notion of our going into our pocket to pay for, you would suggest, larger numbers of things, this has been around for 65 years, right?
Yes, and it's completely acceptable. I have no problem with that. The problem I have is that the division we make is not rational. Why only doctors and hospitals? Why not drugs? Why not home care? It's a 1950s notion of spread, of paying privately, and it doesn't work anymore. So yeah, every country in the world, save a couple, people pay out of pocket, or they have private insurance, usually for 20%. Canada, it's more like 30, but it's never for just one or two things. It's across the board, and that's the real difference. It's this bifurcation that doesn't really work. What's so special about doctors and hospitals? Well, nothing really, except that we have this legislation that's 55 years old that created this division.
What costs more, the trip to the ambulance to the hospital or parking in the parking lot outside the hospital?
Well, if you're in the GTA, it's the parking.
No kidding, eh? Okay, here's your colleague Conrad Yakubuski writing in your newspaper, the Globe and Mail, earlier this year. He writes, as Ottawa scales back healthcare transfers in coming years, already squeezed provinces may have no choice but to resort increasingly to user fees and co-payments for more health care services. Former Saskatchewan Finance Minister Janice McKinnon recently addressed the elephant in the room by suggesting that a portion of public health care services be treated as a taxable benefit. Then there's the unresolved question of whether Canadians should be unconditionally allowed to buy private insurance for medically necessary services performed outside the public system. Pending court decisions could dramatically reshape Canadian healthcare. This does raise a good question about how courts can be influencing what's going to be covered, what our politicians are going to be obliged to do, all of that kind of thing. What role are the courts playing?
Well, the courts are playing an increasingly large role for the reason that I stated before, is that because we're not discussing this, we're not advancing and changing things through public policy, so we're forcing that change through the courts. So we had the Chiuli decision, which was very important, at least theoretically in Quebec. It said that people can now buy private insurance for hospital and physician care.
If they don't get timely care in the public system.
Well, that was added after. That was the response to the decision. So in 6 provinces, it was illegal to buy insurance. Now it's 5. So that changed things theoretically. Practically, it changed nothing because there's no market yet, because Quebec put this proviso that, they'll speed up care for certain things and people won't want insurance. But there's a couple more cases, the Brian Day case in BC, another one in Alberta, that are coming through the pipe, and they're going to win. We know they're going to win, but we don't know what's the practical impact going to be. So my position is always, let's have the discussion openly, let's have it in political circles, make decisions. Yeah, there's going to be, we've always tinkered with user fees, with paying some stuff, but let's decide rationally how to do it rather than, courts don't necessarily make good decisions. They make decisions based on the information they have and on the specific cases they have. And often outliers get to court, not the ones that really, things that really matter to Canadians. So we have to be careful if the courts make our health rules.
I wonder if there isn't a lesson, I don't know, I'm just throwing it out there, if there's a lesson in the United States about all of this. The conventional wisdom in Canada is Medicare's like the third rail. You touch it and you're going to die, right? So politicians avoid it and we live with the mythology, as you call it. But Barack Obama ran on Obamacare, on affordable care, and he got reelected in the middle of the worst recession since the Great Depression. And is there a lesson there, do you think, for us, Trudy, that maybe we should have a little more courage and face these issues as opposed to treating them like the third rail of politics?
Well, we have our own third rails too, and our Medicare program for the elderly is one of them. Politicians are talking about privatizing it, more means testing. It's basically a social insurance program. The benefits used to be, the basic benefits were equal, people paid the same premium, but now we've had some means testing of the premiums and they're talking about more means testing. So there is going to be a debate about that. The question I have is how and if this debate will reach Medicare beneficiaries and people who will be Medicare beneficiaries in the next few years. Because we've had a little bit of this discussion, but it hasn't reached the people who will be affected by it.
But you sort of do have socialized medicine in the United States, right? You've got Medicare, Medicaid, you've got Veterans Administration.
Well, Medicaid is a means-tested welfare program. Okay. Medicare for the elderly is social insurance, or part of it is.
Gotcha. Do you think we're at a point yet where healthcare in Canada is not a third rail issue and we actually can have an adult conversation about it?
Well, there's the rhetoric. We all agree that we need to have an adult conversation. To me, the question is, where can we have it? Where can we have these discussions where it just doesn't get bogged down in partisan politics, etc.? I think we blame politicians a lot for not taking leadership on this, and then we crap on them if they try to. So I think the reality is the public has to rise up and say, listen, healthcare is really important to us. We want to pay for it in a rational way. So help us figure out. I think the politicians essentially have to lead from behind. We have to create an environment where it's safe for them to do so. And we don't have that safe environment quite yet.
Let me just, in our remaining moments here, get each of you to, because we suggested at the opening there are some common challenges in both healthcare systems. And let me just get some sort of snapper responses from each of you on some of the things that we'll have in common. For example, long-term care, Trudy. How's America doing at that?
Very badly. We don't have, we also invest a lot of resources in hospitals and doctors and end-of-life care, and not very much when it comes to care in the community. And so we need a lot more resources put into that, and I understand Canadians have the exact same problem. And the Obamacare Act did call for the beginning of a way to finance long-term care, and that was repealed fairly early on.
How are we doing?
Same thing, we're over-medicalized, not enough community care, not enough home care. Again, it goes back to this bifurcation. It's because hospitals are free, in quotes, and the other stuff isn't. So we've got to shift that.
How about pharmacare here in Canada?
Well, same issue. You know, the single biggest out-of-pocket payment for Canadians is for drugs. So we really have this unfairness that really undermines the philosophy of Medicare. If you have some people who are covered, we have some people in Canada today who are losing their homes to pay for drugs. That's why we created Medicare in the first place. It really perverts the philosophy. We really have to deal with it.
What strikes me is that the absence of drug coverage in your system is very much like the absence of drug coverage in our Medicare program was up until 2006, when a drug benefit became available for beneficiaries. And the arguments seem to be very much the same. And I think one reason why drugs were omitted in both countries was that they weren't a very big deal when these programs were set up. People didn't pay very much for drugs, and there weren't all these wonder drugs that were on the market in the 1960s.
I remember a few decades ago, former Premier Bill Davis likes to tell this story about how they set up the drug plan here in Ontario. It cost $50 million a year, and they worried if they could afford it back then.
Yeah.
It's $1 billion today.
Yeah.
50 million then, $1 billion today. Let's talk about lobbying. Healthcare is a strong lobby in the United States, isn't it?
The doctors and hospitals are very powerful, and the ancillary professions as well. The drug companies are very powerful. All the specialty groups are very powerful. And we, of course, have the private insurance companies, which are very powerful. And you have the same kind of the lobbying pressures here in Canada. Maybe the private insurers are not a big deal here right now, but the providers are. And they have a lot of say in the shape of the healthcare system.
I have heard it said the Ontario Medical Association is the most powerful lobby group in Ontario.
Without question. And the single biggest impediment to reforming healthcare is vested interests. Everybody wants change as long as it's not change to them. That's where we're stuck.
How about technology? How are we doing on that?
Well, you know, we're laggards on technology. We hear a lot about InfoWay, how much we've spent on electronic health records. There's actually been a lot of progress, but it took a long time. It took a lot of money. But, you know, there's a lot of technology coming down the pipe. Medical devices are becoming as important as drugs. We don't talk about them at all. So there's a lot of stuff coming and we're not ready for it as a system. You know, we're not engineered to deal with this stuff. And as an insurance program, we don't know how to deal with this stuff.
We have a lot of technology in the U.S., and that's one of the things people are fearful of. If we adopt another kind of system, we won't get all these new whiz-bang things. But what we haven't done is rationalize the use of the technology, and that's very different from the idea of rationing it, which Americans fear greatly. We don't know. Sometimes it comes on the market. We don't know whether it really works or not. It's very expensive. It gets paid for by Medicare, insurance companies, and it gets filtered down into use long before we really know whether it's effective or there's an alternative that would work better and be cheaper. So we in the U.S. have not had that discussion about rationalizing the use of technology.
How about those who overuse the system, high users? How is America dealing with them?
Well, I think we're trying now to penalize hospitals that have a lot of readmissions. The Medicare program has set up penalties, and this was called for by the Affordable Care Act. And it's really too new to see whether that's going to work and that we're going to sort of keep people out of the hospital who shouldn't be there. But I think we have the same problems here. André likes to talk about some of the high flyers with very outrageous cost profiles for the system.
High flyers, eh?
But we have them too. We just don't talk a lot about them because in the U.S. we like a lot of care. And so I think there's sort of the prevailing wisdom that, well, maybe it's not so bad. You know, these people are getting a lot of care and then they get transferred to nursing homes. And I don't hear it talked about as much as I've heard André talk about it.
Yeah, you do. How about up here?
Well, so You know, we have these frequent flyers. So about 1% of patients consume 25% of the health budgets, 5% consume 50%. Now we have to be careful, they're not necessarily overtreated. They're people with big health demands. That's the very purpose of having universal insurance, is to spread the risk so that we can afford the really costly patients.
Are they mostly in the last year of their life?
Oh, no, not necessarily. It tends to be people with multiple conditions, say addiction, homelessness, mental illness. You know, go into any nurse in any emergency room and they know them by name. We know who they are, we just don't deal with them very well.
Don't deal to, or can't? There are no ways to deal with them in our system.
Well, our system doesn't lend itself well to dealing with them, but we know how to do it. So I give you an example of a homeless person comes into an emergency room 250 days a year. This is a common occurrence. What's the best way to treat them? Is it to patch them up and send them back out into the street to drink Lysol again and come back tomorrow? The solution is to find them a home, find them an addiction program, treat their foot wounds in the street, not necessarily in the emergency room. We know how to do this. We've had 1,000 pilot projects that tell us, but we don't implement it. Why don't we implement it? Because of the way we pay for things. We don't know how to pay for it. So it's all sort of mixed into. You know, I always say our problems in Canada are not medical problems. We prefer great medical care. We have all kinds of engineering and administrative problems, and that's what it comes down to.
One more segment here, primary care. How are you doing at primary care reform in the U.S.?
We have a shortage of primary care doctors. The Affordable Care Act was supposed to kind of ameliorate that to some extent by changing the reimbursements under Medicare that would give them more money. I think we really don't know whether that's going to be effective or not, or whether that amount of money is going to be enough. There's a lot of specialists, sometimes too many specialists in certain regions, and the doctors want to practice where the money is, and there's not a lot of people wanting to go into primary care. So we have a shortage, and I think a lot of people fear it's going to be exacerbated by these the newly insured, who are going to have health problems, and they're going to want to use this new insurance, and will be costly to the system, and there may not be enough doctors to treat them.
Primary care reform up here?
Well, same issues. We need to do more primary care, meaning prevention, and less sickness care. We just do too much waiting until people get sick and expensive, and not enough, you know, cutting it off at the pass. So it's a common issue for both our countries.
Gotcha. Last question here, Trudy. You're sticking around, André, so I'll give this one to Trudy. Is there anything, as you look at our healthcare system in Canada, that you think we can be justifiably proud of?
Yes. You have far more equity in your system than we do. The American healthcare system is very unequal, and I think you can see from those bronze, silver, gold plans how unequal it's going to be. This is going to be baked into the system even more. In Canada, in spite of the problems, in spite of the lack of drug coverage, most people don't have to worry about some of the things Americans have to worry about, and particularly people at the very bottom of our income distribution who are not going to be helped by Obamacare because of the U.S. Supreme Court decision on expanding Medicaid.
Gotcha. Trudy Lieberman from the Columbia Journalism Review, we thank you for visiting us at TVO today. Don't you go anywhere, because we're not done with you yet, because up next, from convergence to cash, do doctors have the right to make a buck? We'll ask that right after this. Laser hair removal, skin resurfacing, Botox injections. Some Canadian doctors have money-making opportunities on the side, and who's to stand in their way, right? But there is a shortage of family doctors. What happens then if those money-making ventures take them out of their publicly funded offices too much? And are there rules in place to govern these doctors and potential financial conflicts of interest that may arise? Joining us now to help answer these questions and others, in Sydney, Nova Scotia, via Skype, Dr. Monica Dutt. She is chair of Canadian Doctors for Medicare, public health specialist and a family physician with the Cape Breton District Health Authority. And with us here in studio, Dr. Karen Dockrell. She is a pediatrician and perinatal specialist based in Whitby, Ontario. And of course, we welcome back André Picard, the columnist with the Globe and Mail. Okay, Dr. Dockrell, should we start with you here?
Absolutely.
You, obviously, you're a doctor, but you had a business on the side that was a part of your practice. What was that called?
That was the Mom and Baby Depot.
And how long did you have that operating for?
It ran from 2006 and really officially closed totally in 2012.
And what kind of services were you offering?
Well, Mom and Baby Depot was what we called a concept clinic. It was put together by families who told us what are the services they used and valued in the early years of parenting or growing kids till school age. We brought all those services into like a one-stop shopping experience. And with it, gave them access through a membership fee to breastfeeding consultants, to nurse educators, to parenting support programs, some dental assessment, preventative health services, dietitians, many others. But really what was the gold feature of the program was what we called a well family care visit, which was 2 hours based on the Bright Futures program out of the United States, what met with a family at the intervals of critical development of their baby and their child and offered them good anticipatory guidance, problem solved with them about any challenges they were having as a family, not just with the health, but with the mom, the dad, and even extended families.
All about keeping people healthier.
Absolutely.
That's the idea. You want a little health prevention, keep them out of the hospitals, treat their sicknesses when they have to, that type of thing?
Absolutely, and gave them the tools to prevent some of those emergency visits and other
And you mentioned you charged your patients a fee for that. What was the fee?
There was. The fee, depending on how old your child was $500 to $2,000 a year.
And people paid it?
They did.
And paid it unhappily, willingly?
No,
what?
Paid it very willingly, and to our surprise, we assumed it would only be a product they'd value in the first year or two of life. They loved it and wanted to keep paying, so that year by year it was well over 95% renewal.
Now that was a payment that was not covered by the health insurance plan.
Absolutely
So
not.
they went into their own pockets for that.
Yes, they did.
Who had a problem with that?
I guess a particular person who was consulted to me made a complaint to the College of Physicians and Surgeons.
And what did they do?
The College of Physicians and Surgeons basically looked at the issue, stating that this particular family felt that they had to pay our membership fee to choose me to be their child's pediatrician. The interesting thing, however, is while I ran my business, Mom and Baby Depot, I ran a full-time consultation pediatric practice, totally OHIP covered. And this family was referred to me as a consultation. They declined the consult and said, no, we want her to give us this service.
Could you be a patient of yours and not be a part of the Mom and Baby Depot?
As a consult patient, absolutely.
But not otherwise?
Not otherwise. And if you look at the details, because we provided well baby visits and immunizations, the college took the stance that we were providing their well baby care. And therefore, if I made a decision to provide a 2-hour well baby care visit, then under block billing rules, which we never said it was a block billing, we identified it as a membership, families should be able to say, well, I want a well baby visit, but I don't want to pay the fee for all the other stuff.
So the college looked into all this, and what did they do?
Basically, through their many different suggestions and legislations, they whittled away the business, and we finally decided to close in a settlement.
You had to hire lawyers.
I actually was represented through the Canadian Medical Protective Association.
Okay, so your premiums went towards your insurance coverage, which covered your legal fees.
That's right.
How much do you think it cost, though?
Oh my goodness, for my legal team, I'm sure it's upwards of $500,000. I wonder what the college spent and the investigations that they went through. And for us, it was a steady financial loss in trying to keep the business afloat and try to build to their satisfaction at what they were trying to do.
So at the end of the day, you shut it down.
We had to shut it down.
Are you still practicing?
I practice, yes I do.
But
My
without this?
consultation practice continues to this day and has flourished.
I read somewhere in I think in the National Post that you're thinking of leaving Canada because of all this.
Yeah, you know what, I was. And in fact, quite honestly, I was advised that I should. That the college would always be on my case, shall we say. And so I looked out at other options. My family is here, but my biggest challenge is that my license in Ontario remains restricted. which limits me applying for other positions. It limits me bringing in partners, supervising young doctors, and many other things.
Restricted because you ran afoul of the college?
Because I ran afoul.
So if I go to a post office, your poster's going to be there.
You're
it's wanted.
Huge. If you go to the college site, I don't look like a very friendly person.
Okay. Let's get some feedback on this. Dr. Monica Dutt, what do you think of this story?
Well, I think it's fairly straightforward when we're talking about private for-profit care that people shouldn't have to pay for medically necessary services. And I think that's you can debate what's medically necessary or not, but in our system, you don't need to pay for things like immunizations and well baby checks. So I think it's fairly simple that people don't need to pay for that care. It's a little different when you're talking about for-profit aspects of it. So doctors are able to charge for other services that they may be offering. But I think in this situation and in others, you do get into difficulties when they're being offered under the same roof, because you get into situations where there's the potential for profit to be the motivator as opposed to the care of the patient. And there's lots of examples of that, of people getting more testing than they needed, more treatment than they needed, because there is a profit motive either for the physician or perhaps for the investors in a company. And then the other aspect is the perception of the patient. So even if it's perfectly clear to the patient that they don't need to pay a fee to access certain care, they may think that they should pay that fee in order to get good care, even for things that are normally covered. Or they may feel like if they don't agree to the other services that they're being offered, they may not get good care overall. So I think there's different issues that come up, that both they shouldn't have to pay for medically necessary covered services, and that there's also the perception of the patient not being able to get good care if they don't pay that fee.
Okay. André, you're here as the kind of honest broker overlooking all of this. This is one story, but I wonder how common this story is, namely a doctor's attempt to make some extra money outside of what is covered by the Ontario Health Insurance Plan. How often does that happen in our system? Well,
we have a lot of doctors who work strictly on the government plan in the province they're on. They get all their income from that. That's easy, cut and dried. We have a very small percentage of doctors who opt out entirely. All their business is private. That's simple too. It's the little, what do we do with people who straddle both? That's the really difficult one. Cases like this are not cut and dried, but what's wrong about this case is that the unfairness of it all. So
unfairness to whom?
Well, to Dr. Dockrell, for example, and to the public, because they're not sure what the rules are. Because there's all kinds of clinics like this that exist with fees, with membership groups for adults, and they're perfectly fine. They don't get pursued by the college. People are willing to pay it. Should that influence our legislation? These are really difficult areas. So what we're doing is, as Dr. Dutt said, is we want to ensure that people get medically necessary care, that they pay for it. They don't feel pressured that they have to pay extra to get the care. How do you do that? How do you allow that and still have people straddle the line? So there's all kinds of gray areas, and they're getting grayer, if you will.
But let me ask the overarching question, which is, should we have a problem with a doctor who wants to supplement his or her income by offering services on the side to willing patients that are not covered by OHIP?
Well, that's not a yes or no answer, I don't think. I think I would answer it by saying that in a lot of the world, in the developed world, in universal health systems, that exists. So all over Europe, you have this mixture of private and public. What they have that's different from us is much more clear regulation. So I would say to you, I can justify saying 100% we ban all mixing, doctors are either private or public, you have to choose. That could be justified. But that's not the system we have. We have a system that kind of allows it, but it's not sure when. So I think it's what's required more than anything is some clarity.
Let me see if I can get some clarity out of Monica Dutt here. I presume from your first answer that you're not a fan of what Dr. Dockrell was attempting to do. So I want to ask you, do you charge patients for anything outside of what OHIP covers?
I don't. And just to maybe expand a little bit, I wouldn't say that I disagree or agree with one model or another. I think, like André was saying, there's certain things that need to be clarified about what the best way to put a new model into place is. And for Canadian Doctors for Medicare and myself, I think there's certain criteria that you can try to evaluate to see whether the new model that you're proposing will actually improve the health of your patients. So some of the things you need to look at is it a fair system? Can people access it? Are there there are barriers. So I would say most of the single mothers that I see can't afford $500 to $2,000 a year or whatever the fee might be. So I think that creates a barrier. Looking at, is it high quality care and is it clinically indicated care? So are patients getting care that they should be getting? Are they getting extra care?
Okay, no, I get you, but I want to keep focused on this issue of what's covered and what is not. We know of stories where there are family doctors, for example, who charge an annual fee just to be on the roster of this family doctor. We know if you ask your doctor to write a sick note for you, they will charge a fee for that. If you want to leave that doctor and go to another doctor, they may charge you a fee for putting all their files together and you know the work that's required to organize those files, and then so you can take them with to your new doctor. Do you do any of that?
I don't. I don't personally do it.
And do you think doctors should not be allowed to do it?
I think it does take physician time and effort to do that. So I think looking at how the different colleges across the country have dealt with it, they've at least put out rules and guidelines around what is reasonable to charge for all of those things. And doctors need to explain to their patients if they're charging more than those things. So I think things like sick notes and patient transfers and phone prescriptions, there are guidelines and rules out there that help doctors to be able to charge what seems to be a reasonable fee. And they do have the option for not charging it. And in my case with my patients, many of them, I don't charge it because, to be honest, I think doctors do make a reasonable wage, a reasonable amount of money, and I don't need to charge someone $10, $20 for something that they might not be able to afford. So I think doctors have that option, and I think colleges...
Well, what about charging it to people who can't afford it and just not charging it to people who can afford it?
I tend not to do either. I think that doctors are paid reasonably for the things that they do, and I don't feel a need to charge extra. That being said, there are guidelines that put out reasonable amounts to charge for things like that, things like sick notes and other things that aren't really quite costly, but for some people they are costly.
Okay, let me go to Dr. Dockrell with this. You knew when you were doing this, you're kind of, you're nudging up to the edge of, what's kosher in this country, right?
Absolutely.
And you knew you'd be, spitting in the face of some regulatory bodies or, for example, people who share the view of Dr. Monica Dutt that think that what you're doing shouldn't be allowed, but you did it anyway.
Right. I did notify those bodies, though.
You notified them, okay. Yeah. But did you at any point in this process think to yourself, I'm just inviting a whole heap of trouble upon my head here. Why don't I just do this and not charge all the extras, and I can look like I'm very close to God on all this, and I won't have any legal fees?
You know what? It was an interesting time, because in 2006, a group of private clinics were looking at coming into Ontario from BC. And they were in the press, and at that time, the then Minister of Health made it very public and said anybody will be charged a fee or will have to pay a fine if you provide it and or you buy it. So when we opened, they weren't running through our door, to come in. And yes, we recognized we were on a cusp, but we felt very much, and my background, having worked in hospitals and worked with mothers and babies, felt very strongly that there was a detriment to the services they needed, and if they couldn't access them. So the best example is breastfeeding. Probably the best public health initiative ever. Mm-hmm. It's got a long-term payback, but you have to be able to wage through there to get it. I felt very much that I needed to find a way for women to get it.
So why didn't you just offer the service and have OHIP pay for whatever OHIP pays for in that case?
The OHIP pays for none of it. And in fact, my question to OHIP was, what can I bill if I assist a mother with breastfeeding? And they told me zero, that OHIP does not cover breastfeeding support.
Does that make sense?
Well, it doesn't make sense, but that's the unfairness part I pointed to. I can go out and hire a breastfeeding consultant tomorrow, pay them whatever I want. She won't be pursued by the college. If that person happens to be a doctor, they will be. So what sense does that make? I can hire a doula, pay her whatever I like, but I can't hire an OBGYN to do extra stuff for me.
But my recollection is, been through this a few times, when you have a kid, not me, but when a child is had in the hospital, somebody in the hospital comes and gives advice on how to breastfeed, right? Doesn't that happen?
Fairly brief, though. Your hospital stay is at max 60 hours. In the hospital, the nurses are all given some training in breastfeeding. Most hospitals may have one, perhaps two lactation consultants.
So you were offering above and beyond.
Oh, breastfeeding really requires the support in the first 2 months. help families understand it, stick with it, keep going. And our outcome for breastfeeding was 80% success and continuation at 5 months.
So worth the money in your view?
Well worth the money.
Well worth the money. Let me read this. This is from healthydebate.ca from just a couple of weeks ago. This is from Nan Okun, an OBGYN at Mount Sinai here in Toronto, who recently blogged about traditional obstetrical and gynecological practices and also offering aesthetic or cosmetic procedures. She writes, "One concern I have is around a potential professional conflict of interest that might come from having the same OBGYN delivering both insured and non-insured services under the same roof. For example, I worry that women seeking medical advice and counsel concerning sexual health will be influenced, consciously or not, to purchase products or undergo expensive procedures that are not medically necessary." Now, André, in your view, has she put her finger on a potential conflict of interest that doctors find themselves in?
Oh, it's definitely a potential conflict of interest. The issue is, how do you manage it? And so, again, I come back to, how does the rest of the world manage it? Well, they manage it with pretty strict regulation. So say you're in Europe, you're an OBGYN, you do your public service, and it's laid out. If you want to practice in the private sector, then you have to put in X number of hours in the public service. So it's all legislated, regulated. We don't have that in Canada. In Canada, we have, well, you really shouldn't do it, but if you do it, we're not sure we want to know about it. There's just a lack of clarity, and it's not fair to the physicians. It's not fair to the public.
Dr. Dutt, would you like to see a prohibition on this type of activity altogether?
I think, again, I wouldn't say a prohibition altogether. It's taking each model case by case and seeing if it compromises patient care. So, for example, in Toronto, there's the Kensington Eye Institute, a private not-for-profit site that does provide care and doesn't charge patients beyond what it would cost for the procedure. So I think there's ways to do it. And even looking at the breastfeeding example, I am normally working in public health, and no question, breastfeeding is essential, but I would like everyone to be able to access similar levels of care as opposed to just the people who are wealthy who can afford the care. So I think we need to look at ways to make it accessible to more people as opposed to just the people who can pay for it.
Dr. Dockrell, should we be concerned that if doctors have this added interest on the side, that it, never mind the business case, it might actually take them away from the time that they might spend doing health insurance plan covered services that we need?
Right. That was an issue that was raised with me. As I say, I ran a consultation practice at the same time I did it. As the Mom and Baby Depot grew, without doubt, I had less time for my consultation practice. However, I work pretty heavy hours per week. And if I was, as many female physicians choose to work only 20 hours a week, does that take time out of the public service? I was actually told at one point that if I choose to give a 2-hour well baby visit to my membership, then I need to give that 2-hour well baby visit to anybody who wants it and get paid $32. Now we can all see that's not practical. My choice was to make sure that I balanced and that I followed the code of ethics. In making sure that I didn't impose unreasonable expectations on families.
But here's an example you hear, André, and help me understand whether you think this is right or wrong. You take your kid to the doctor. A kid goes in, gets a checkup. Nasty cough. Doctor says, probably should get those lungs x-rayed. Go down the hall, make a left. There's an x-ray room there. Here's the form. Get your x-ray. Oh, by the way, I own that x-ray lab. The doctor. Is that a problem?
Well, there's again a potential for conflict, right? Are you going to order more x-rays because you're going to get a fee on that?
How could you not?
Well, a lot of
how could you not be perceived as not, because of the financial interest, how could you not be perceived as saying, of course I'm going to send you for more x-rays when in doubt because I make money from it?
Well, a lot of doctors think they're immune from that. They think they're immune from visits from pharma reps, etc. So the question is, I think openness. The public should know that that's the case, first of all. Can we ban that? I'm not sure we can. There's all kinds of gray areas. What happens when, it's not just x-rays, there's pharmacies. So what happens when a doctor's office gets free rent from the pharmacy that's downstairs? Because they know the patients, 90% of them, hey, there's a pharmacy downstairs, I might as well fill my prescription right now. Do people know that? Generally not. This was a big case in Quebec where there was an ethics debate about that and the college ruled on it. But there's 1,001 of these things. What about the doctor who works 4 days a week, does wonderful care, takes Fridays off to do Botox treatments and makes more than in the rest of the week?
Right.
Is that worse than what Dr. Dockrell was doing, charging $500? It's, I don't know, maybe the college should have better targets, I'm not sure. But it's the unfairness of it that I keep coming back to.
Dr. Dutt, it does sound as if it's, Andre's made a good point here. It's hard to, I should ask, is it difficult to operate, quote unquote, ethically as a doctor in any province in Canada today because of all of these potential built-in conflicts or some of the other things we've been talking about here tonight?
I think it is, because I think it's not just the perception that your doctor might be asking you to do something to make money. I think we do have evidence that it has happened, not in all cases, but there are studies and examples that show that people do get more treatment, do get more lab work, do get more imaging done. So we know that that can happen. So I think you do need to be careful. So even with Botox injections, for example, keeping it separate, it's not necessarily that I'd say don't make the money off the Botox injections, but making it clear that it's separate from the patients that you're seeing and not just referring them because you know you can make that money from them. If you think that it's what they need and if it's good patient care, because I think ultimately that's what physicians should be doing, advocating for good patient care, then you can argue for it. But if the profit becomes the primary motive, then that's when it shouldn't be the acceptable thing to do.
Okay, here's the follow-up though. And that is that, yes, doctors obviously do no harm. You've got your Hippocratic Oath. You obviously don't go through 10 years of medical school or whatever it ends up being, because at the end of the day, all you care about is money and you don't care about people. Having said that, doctors are self-employed professionals. They are, in some respects, entrepreneurs as well. Do you really want to take the entire business side of the equation away from them?
I think, again, doctors make a reasonable amount of money. There's a lot of discussion right now around how much doctors make, even if they don't charge privately. So our physician associations negotiate contracts, negotiate fees. They're able to make their wages in that way. And if they feel they need to make extra money, that should be done in a way that does not compromise the care of the patient that they're seeing and does not lessen any of the access to things that are covered. So I think that we're able to make a reasonable amount of money and it shouldn't need to go into profit. But if you do, then it needs to be separate from the patient care that you're giving that is covered under Medicare. And I think it is a bigger discussion of what is covered. As André mentioned earlier, there's lots of things that aren't. A lot of pharmacy, long-term care, home care, all essential parts. But in our system, we do cover physician and medical and hospital care. So those things at least need to be protected.
Dr. Dockrell, I'm just curious. If I asked you before all this started and you had just set up your depot, if I said, describe yourself, what's your title? What's the first thing you would have said?
For Mom and Baby Depot?
Yeah.
I was the medical director and owner.
If I said, are you a small business person? What would you?
Yes, I was an entrepreneur.
You were an
Yes, I
entrepreneur
was.
as well.
Yes.
Did you see anything inconsistent between being a doctor and being an entrepreneur / small business person?
I was very careful, I believe, in making sure that I maintained my OHIP practice and what I saw as an OHIP practice. It was very interesting in Mom and Baby Depot in that we did provide immunizations, but we had to bill OHIP for that piece of it. So the membership fee families paid did not include what we would bill to OHIP. And what was interesting in the model is as we identified that there were more and more mental health needs for our patients, we had to find a way to keep interacting with OHIP to help families avoid having to pay excessive fees. Our challenge was to find the right fee to match the service they needed.
There are some people, André, in this country, lots of people I suspect, who believe that doctors ought to be doctors and that's it. And this notion of being self-employed professionals or this notion of being entrepreneurs or small business people really ought not to enter into the conversation. Do those people need to get over it?
Well, the reality is most doctors are just doctors, right? So the debate we're having, we don't know what percentage of doctors it applies to, but it's a small percentage. So as Monica said, most doctors are well paid under the public system, whether it's fee for service or salary, and they don't get into this. But the question is, do we want to discourage the minority of entrepreneurs. And I don't see any benefit from doing so. Why would we want to discourage that? We talk about the need for innovation. You know, we need people who push the boundaries, even if it makes us uncomfortable. That's how things change. Sometimes they change for the worse, that's life, but often they change for the better. So I think we want to encourage this, but to me it's about good regulation. It's about articulating, well, why would we restrict things?
Which we are not doing.
Not in any way, I don't think.
Not in any way.
No.
The College of Physicians and Surgeons in Ontario isn't doing it.
Well,
the Canadian Health Association isn't doing it.
What they come back to is, you know, the two most important words in the Canada Health Act, medically necessary. They're not defined. Well, what does it mean? So depending on the where you work, you know, if you're working with kids, they're a little more, the definition's a little stronger than if you're working with adults. Well, why? So there's a lot of unanswered questions there.
We've got a few minutes left here, and I want to finish up on this. This is a quote from Dr. Ian Bookman, a gastroenterologist at St. Joseph's Health in Toronto, also medical director of the Kensington Screening Clinic, who also blogged about the issue of private clinics offering public services. And here's what he said. In my opinion, there are two reasons why people are against private clinics, and both have to do with fear. Number one, fear of change of the status quo, and number two, fear of the word private. Subscribers to these misperceptions offer fear-mongering stories, conjuring images of substandard private clinics with illegal practices that abuse the healthcare system, stealing public money in the name of greed. These perceptions are inaccurate and misleading. Here are two truths that should replace these misperceptions. Number one, the status quo needs to change, and number two, private is not a curse word in medicine. Dr. Dutt, let's start with you on this. Do you think private is a dirty word in medicine?
You know what, I'd agree with both of those premises. So it's not private, that's the dirty word. I'd say it's for profit, that's the dirty word that we need to have more conversation about. But that is the difficulty you get into when you start bringing into the for-profit aspects of things, because then that starts often, not always, but often to erode some of the basis of our Medicare system. And I agree with this first premise. The status quo isn't acceptable. We've, as an organization, been advocating for changes in a number of different areas, and there's lots of great examples across the country. It's not about what model of care should we be, it's about the types of models of care that we should be using, and not the private side of it, but the for-profit side that needs to have the bigger discussion.
Do you want to make a distinction between what's private and what's for profit? In other words, one's okay, one isn't?
Good question. There are many public services that are delivered by private agencies, and that's often not well understood by the public. Labs in particular are all privately owned. They provide public services and get paid a fee for that. I think the whole issue is that private delivery of public services can be done well. It can be done to expand the services that we now have. And I believe in the hands of people who are ethical and value our universal healthcare system, it will improve universal healthcare.
André, last word to you.
Well, it comes back to a discussion we had at the outset of the show. You know, Tommy Douglas never said everything should be covered, right? But the question is, how much do you allow people to buy the other stuff? So how much should the Medicare system, the public system provide? What are the essentials? And then once we've decided that, well, what do we do with people who want more? Do we allow it? Well, why not? You know, is it going to harm the others? If it doesn't harm others, if everybody gets basic, really good care, then what's the harm?
What's the harm? And it's always about harm in medicine, isn't it? It's
Absolutely.
supposed to be. Are you totally sick of our healthcare system right now?
No, I'm not.
You're not disgusted with the whole thing?
I am not.
No?
I would love to see our universal system include dental care, some eye care, many, many other features. But I, like many others, want to know what medically necessary is. And if it isn't in our public pocket of what we can provide, then I want to look at some good low-risk insurance availability to people to receive those services.
Gotcha. Thanks, everybody, for this discussion. Dr. Monica Dutt via Skype in Sydney, Nova Scotia. She's with Canadian Doctors for Medicare and with the Cape Breton District Health Authority. Thanks very much, Dr. Dutt, for being there down east for us. Dr. Karen Dockrell, the pediatrician and perinatal specialist from Whitby, Ontario. André Picard, who we read in the Globe and Mail. How often are you in the Globe? You're in there at least a couple times a week,
At least a couple of times.
At least a couple times a week. There we go. Thanks so much, everybody.
Support Ontario's public television. Donate at tvo.org.